Thank you for your kind introduction, Chairman. And I'm Namkee Oh from Samsung Medical Center. Today, my talk is about principles of transfusion in ABO-incompatible liver transplantation. Okay, the entire journey of ABO-incompatible LDLT is defined by the strategic management of blood components. From the very first step of transplant desensitization, where we clear preformed antibodies from the recipient's plasma, to critical intraoperative phase, where we choose specific blood products to protect the graft. And finally, to the post-transplant period, where we manage antibody-mediated rejection and aim to induce long-term accommodation. Therefore, this hematologic management is a core therapeutic strategy for the success of ABO-incompatible LDLT. To understand where we are today, we must look back our history. Now we have a deeper understanding of AMR, but in the early days of liver transplantation, this mechanism was not well understood. So this brings us to the pioneering work of Dr. Thomas Daza. In his earlier experience, he performed 11 ABO-incompatible liver transplantation in pediatric patients. As you can see from his paper published in 1979, acute rejection was not observed, surprisingly, and the outcomes were quite favorable. Why did this transplant succeed without any desensitization protocol we do today? The leading hypothesis is that it was because the pediatric patients, they have relatively immature immune system, so their bodies just did not have strong antibody response we would expect. But this early optimism did not last long. The story changed completely in 1980s. This is when the field started including the adult patients. The results were very disappointing. The reason was hyperacute and antibody-mediated rejection. And because of this, the procedure was essentially abandoned. And for a long time, ABO-incompatible LDLT was considered as contraindication. To overcome this hurdle, the first desensitization strategy was clearing pre-existing antibodies from the recipient's blood. The main tool for this was plasma exchange. The goal was simple. Just before the transplant, you physically filter out the recipient's ABO antibodies from the plasma. But there was a fundamental flaw in this approach. Plasma exchange could only remove the antibodies that were already there. It did nothing to stop the B cells from producing a whole new antibodies. As a result, we saw a rapid antibody rebound shortly after the transplant. So even with frequent plasma exchange post-operatively, this rebound often led to severe AMR. So this brings us to the early 2000s. The game changer was introduced, rituximab. This was the missing piece of the puzzle. While the plasma exchange could remove existing antibodies, rituximab addressed the source. As a monoclonal antibody against the CD20, it effectively depletes the B cell population, preventing the production of new antibodies. So the first clinical success was reported in kidney transplantation in 2002, and this was quickly followed by the reverse in liver transplantation. And the data confirmed its effectiveness. As you can see from the flow cytometry results, the CD20 positive B cell counts drop to almost zero after rituximab is given, and it stays down long after the transplant. And this was a true game changer for this field. And rituximab, after the introduction of this rituximab, things changed very quickly. So rituximab-based protocol were adopted by many centers, becoming the new standard care. As you can see here in the treatment timeline, The outcomes for ABO-incompatible LDLT showed a dramatic improvement. The 3-year survival rate jumped to the over 80%, and the incidence and the risk of AMR also significantly decreased. So now in the modern rituximab era, both graft and patient survival for ABO-incompatible cases are comparable to the compatible transplant. So far, we reviewed the history of immune modulation strategy for the ABO-incompatible LDLT. So now let's get into the more detailed view of why this preconditioning is so critical. The ABO antigens are not just on the red blood cells. They are widely expressed. Most importantly for us, these ABO antigens are also expressed in the endothelial cell linings in the liver sinusoid and vessels and even bile ducts. So when the liver graft is transplanted, the recipient's pre-existing anti-A or anti-B antibodies immediately bind to these antigens on their graft endothelium. So these bindings triggers a powerful inflammatory response. It activates the complement cascade, leading to a direct immunological attack on those endothelial cells. And all the preconditioning we do is designed to create a safe environment for the graft to settle into the recipient's body. And the transfusion can act as a major disruptive factor to this careful optimized environment. So it must be done with extreme caution, and inappropriate choice of blood product can lead to rejection. So to understand the risk, we need to break down the blood product we use today. So let's start with red blood cells. It contains A and B antigens on their surface. So the primary risk for RBC is introducing the wrong antigens to a recipient who has antibodies against it. Next, we have fresh frozen plasma. It contains a high concentration of anti-A and anti-B antibodies. It has no cells, so there are no antigens. The risk here is transferring plasma that contains antibodies that could attack the donor's graft endothelial cells. And the platelets, they are a little bit more complex. The platelets themselves have a low level of antigens on their surface, but critically, they are suspended in a significant amount of plasma. And this means platelet transfusion carry a double risk. It can introduce antigens and antibodies together. So before we go into a specific transfusion rules, it is helpful to quickly define the types of ABO mismatch we encounter. Not all mismatches are the same. First, we have major mismatch. This is the classical scenario we have been discussing, and it is when the recipient has pre-existing antibodies against the donor's antigens. This is the highest risk situation. And next, there is a minor mismatch, and this is a reverse situation. So here, the graft itself carries B lymphocytes that can produce antibodies against the recipient's blood type. So this is generally a lower risk than the major mismatch. And finally, we have bidirectional mismatch. And this happens when both major and minor mismatches exist at the same time. For the hematopoietic stem cell transplantation, the transfusion guidelines are very well established, and multiple papers and society guidelines give clear evidence-based recommendations. However, when we look at the solid organ transplantation, the evidence is very weak, and as a result, guidelines and protocols can vary significantly from one institution to another. So given this lack of clear standardized evidence, the Korean Society of transfusion specialists decided to investigate the consensus here in Korea. So to do that, they conducted a survey in 2020, and 34 specialists from the country participated. And the goal was to understand the real-world practice for blood component selection in ABO-incompatible solid organ transplantation. So the key findings of the surveys are here. So for the red blood cells, the most common choice was the recipient's blood type, selected by over 70%. However, for the platelets and plasma, the majority preferred group AB and AB, and about 40% choose the use of donor's blood type. So the guiding principle for the RBC is simple and fundamental. The transfused red cell must be compatible with the recipient's plasma. And this is to prevent the hemolytic transfusion reaction, which is our primary safety concern. So based on this, primary choice is to use the recipient's own ABO group. And the second choice is group O. And a packed red blood cell unit still contains 10 to 15 milliliter of plasma, which has antibodies. However, the evidence suggests that the immunological risk from this tiny amount of antibody is insignificant and unlikely to cause AMR in the graft. And then the specialists were asked to explain the reason behind their choice for the plasma and platelets. And the answers were very practical. Specialists who choose the donor's blood group often did so because the shortage of group AB plasma. And on the other hand, those who choose group AB did so to simplify their transfusion workflow and minimize the risk of errors. So these findings lead to two main conclusions. First, the transfusion policies for these transfusion policies can vary among the institutions. And the second, there is a clear clinical preference for using group AB plasma whenever it is possible. And why is that? Because group AB plasma is widely known as universal donor. By definition, it does not contain anti-A or anti-B antibodies. However, However, the universal donor does not mean that it's immunologically inert, because AB individuals express both A and B antigens, so their plasma is rich in soluble A and B antigen substances. So if the ABOi recipient have any residual antibodies still circulating, these antibodies can bind to the soluble antigens transfused with the AB plasma. So this forms high molecular weight immune complexes. And these immune complexes can circulate and cause significant problems. For example, they can attach to red blood cells and cause hemolysis, or they can bind to platelets, triggering activation and premature clearance from the circulation. And on top of these immunological risk we just discussed, there is also a major practical challenges. Group AB is the rarest blood type in the world. As you can see from this data, it accounts for only about 5% of the global population at most. So this scarcity creates a very real supply problem. It makes it difficult to standardize the use of group AB plasma for all ABO-incompatible transplantation. So considering this immunological risk and the practical supply issue of group AB plasma, the British Society of Hematology provides a recommendation. For a major ABO mismatched solid organ transplantation, the plasma should be of the donor's ABO group. And so based on the expert survey from the Korea and the existing literature, the society also proposed this recommendation. So for the red blood cell, primary recommendation is to use the recipient's blood type. And this is the most common practice and is efficient for blood inventory management. And the second choice is Group O as a safe alternative. And for the plasma and platelets, the primary choice should be the donor's blood group. And the Group AB is a second choice. So far, we have focused on the major mismatch scenario. However, liver is kind of major immunological organ, packed with a high volume of the donor's own lymphocyte. And because of this, the donor's immune cells within the graft liver can survive and become activated inside the recipient's body. And that is why we must also consider the risk from this minor mismatch component, which is present in the case of bidirectional mismatch. The activated donor B lymphocytes produce antibodies that react against the recipient's red blood cell antigens, and this causes the recipient's red cells to be destroyed, a phenomenon we call immune-mediated thrombohemolysis. And this entire process is known as passenger lymphocyte syndrome, PLS, and it is the limited form of graft versus host disease that appears in solid organ transplantation. So the underlying mechanism is minor mismatch, and this is why bidirectional mismatch is a classical and high-risk scenario for developing this PLS. So to avoid adding any incompatible antibodies that could worsen the situation in bidirectional mismatch like an A to B or B to A transplant, we strongly recommend use Group AB plasma. So the next important question is, how long do we need to continue this policy of non-identical transfusion after transplantation? Here is the experts, here again, expert survey showed a very wide range of opinions. So the most common answer was from nearly 60% of the specialists was that this policy should be maintained permanently. But on the other hand, about 12% said that they maintain this special protocol for 4 weeks. To understand why they say 4 weeks, the concept of accommodation is important. It is not just the same as the classical tolerance. The anti-donor antibodies does not necessarily disappear from the recipient's blood. Instead, accommodation is a state where the transplanted organ itself learns to resist injury from those circulating antibodies. The grafts and the endothelial cells adapt over time, and they upregulate protective mechanisms that shield them from the complement attack. So this process is generally thought to be established within the first few weeks after transplantation. So that's why that 4 weeks time framework we saw in the survey makes sense. However, when we look at the international guidelines, they disagree each other. The British Society of Hematology, they recommend 4 weeks to continue this non-identical transfusion, but Australian and New Zealand Society, they recommend using non-identical products for the entire transplant period. Okay, so to conclude, as I have revealed today, ABO-incompatible liver transplantation carries a unique set of immunological risks. Thus, we must be strategic and cautious with blood transfusion through the entire transplant journey. So bringing everything together, these are key takeaway messages. First, modern desensitization is the cornerstone of our success, thanks to plasma exchange and rituximab. And second, transfusion is a core therapeutic strategy in LDLT. Especially remember that universal group AB plasma is not immunologically inert. So it carries soluble antigens that can form immune complexes, a risk we must always consider. And then There is no clear consensus about the optimal duration of non-identical transfusion. And finally, always consider passenger lymphocyte syndrome in bidirectional mismatch cases. Okay, thank you for your attention.